Good morning, everyone.
Well, good
Well,
morning,
thank you very much for
everyone.
joining us today in this event. It's a pleasure to have you with us tonight for some people, of course. This is a very unique roundtable that we have put together. We're aboard taking the concept of urban public health, and we'll be talking about it between two important areas of the UMass, the University of Massachusetts area of public health in Boston, and the Department of Public Health in the School of Medicine at the National University of Mexico in Mexico City. Before we start, I'm going to introduce you with our guest, and I will introduce myself as a moderator of this roundtable. I will start with my good friend Phil. I will try to do my best with your last name, Phil. Phil Nyakauru, which is
you can call me Phil Gona.
Phil Gona. So Nyakauru is your middle name?
Yes.
Okay, good to know that. I feel like we're such a close friends, and I didn't know that was the middle name. Dr. Gona, Phil Gona, he has a master's in public health in epidemiology and a PhD in biostatistics, both degrees from the Boston University. His areas of expertise are statistical methods for public health, chronic and infectious diseases, and time-to-event analysis and meta-analysis, as well as global health. Currently, Phil Gona is an associate professor in the Department of Exercise and Health Sciences, all of these in the College of Nursing and Health Sciences, of course. Thank you very much, Phil, for joining us. I have to say that we were expecting to have the presence of our friend Ling Shang, but she is not available today. She has a personal issues that won't allow her to join us. She apologizes. So I just wish our friend Ling a speedy recovery and wish you the best. Having said that, I want to go ahead and introduce Luis Durant. Luis Durant, he has a master's in public health with an emphasis on area of health administration, health services administration, and a PhD in the area of health services research. And of course, he can elaborate more of that. Most of his life he has devoted to the area of health services research and the impact and access and inequities and so on regarding his health services research. He studied at the School of Public Health at the University of Michigan in Ann Arbor. Thank you, Luis, for being here and enjoy Mexico City for us. With us is Dr. Malaquias Lopez. He has an MPH and a PhD in epidemiology from Yale University. His areas of expertise goes from chronic diseases to infectious diseases and all these kind of cohorts and prospective studies that he'll elaborate more on that. And both Luis and Malaquias are both in the Department of Public Health and the School of Medicine in Mexico City. I don't have to mention that Phil, as well as Luis and Malaquias, have a very extensive number of publications in all specialized magazines and journals, as well as chapters in books themselves. They belong to a number of very, very relevant medical and public health associations and epidemiology associations, and that they have devoted to their life to research and teaching, which is pretty much the essence of what brings us today to this roundtable. Last but not least, I should say this because I'm introducing myself. My name is Javier Laguna. Myself too, I'm an MD from the National University of Mexico. I have a degree in public health from the School of North Carolina in Chapel Hill in the area of health administration, and a doctorate in public health in community health planning from the School of Public Health at the University of Texas. Currently, I'm the director of the Center for Mexican Studies of the University of Mexico here in UMass. So we're having a representation area, an office in UMass, and we will be happy to welcome you here. So having said that, and just being aware of time, the topic today is urban public health. And the idea is to have a conversation on this, to understand what, for you that you follow us, what does it mean urban public health? We have the idea urban versus rural. Is that all what it is? Or is there something more in the urban that takes us into the larger populations? When is urban, are suburbs urban or not? Where is the limit of this definition of urban? When does it go to a city? And when do we talk about the mega cities and all these situations that create a number of health determinants in the urban areas that are different from the rural areas? And we know that cities have a number of issues that make it more interesting or more complicated to have interventions which are different, which is the aim of public health, to intervene to alter the course of diseases versus the rural areas. The problems in the cities, we know them. I mean, just the population density to start with is a very important factor to carry diseases. COVID is an example how the cities face different challenges than the rural areas, but as well with the pollution, the environment, the contamination, the area of mental health, and so many issues that we are going to be talking today. So to start with this, I'm going to present with a very interesting way to approach this. And this, I have to say that this came from my good friend Luis Durant, talking about this roundtable. He mentioned a very important expert that he passed away, I believe, at the beginning of this 21st century. His name was Oscar Gish. He was a historian and an economist. That he worked for WHO many years in different countries. But I understand that his last 2 decades, or almost the last 15 years or 20, he was with the University of Washington in the state of Washington. But talking about his work during the 80s, when primary healthcare was very important, there was a movement to call it selective primary healthcare. And this is a conversation that Luis and I had. And from there, he said that he was wondering if the term selective primary healthcare was old wine in the new bottles. I mean, it was something that we knew that, and they just had a new label to put that. So with that approach, Phil and Malachias, is the term urban public health old wine or in new bottles? Or is it something really a new construct that we have to define? We have to understand the limits. What is the evidence of the contribution that it has given to society to divide public health in just urban? Do we want to educate the new generations just in urban public health? Or what are we talking about that? So I think, Luis, that this is a very interesting way to start with this. And just feel free to start with this conversation. I don't know, Malachias, if you want to maybe put some concepts on the screen, and so we can go after that and let's have a conversation among ourselves. So please, Malachias.
Well, you may hear the bell of the trash collection.
Well, that's part of the urban public health, see?
Yeah, but perhaps it's better for Luis to begin until this passes here. Okay, so go ahead, Luis.
Do you want me to jump in?
Well, if you want to, Phil, I think it will be good.
Yeah, I can do that very quickly. Thank you, Javier, for opening up the whole discussion. Your main question is, what is urban public health? Is it a new wine in a new bottle? What's different? How does it differ from rural public health? The way I think about this question, and this will lead us into how we developed our own program in urban health. It's really surprising that today in 2020, we're beginning to have programs like ours that focus on urban public health, yet as early as 2000, people started writing that urban health is a new discipline. What do they mean by that? They mean that the population structure is changing. People are occupying urban areas much more than they used to be in the past. One of the books that I'm reading is written by the Dean of the School of Public Health at Boston University. His name is Dr. Galea. He started writing, him and his colleagues, way in 2000, that we need to start addressing public health because of the shift in residential settings that is happening. And not only that, urban areas provide an avenue for us to make a larger impact in terms of health than ever before. When I think of health today, I mean, the traditional way of thinking about health, people think about health as if health is about medicine. Health is not about medicine. Health is about preventing diseases. So urban areas provide a fertile ground for making the most impact in preventing disease so that we will not need to go to the medicine model each time an individual gets sick. We're trying to stop the disease before it happens. Now, how does that fit into our program at UMass Boston? The traditional public health program focuses on international health, global health, or all other these traditional disciplines within public health. But our program at UMass Boston tried to leverage into this urban component that has been left behind, that has been identified like in 2000, as I mentioned. We live in a big city like Boston, where the majority of the individuals are immigrants. The majority of people who are immigrants live in crowded areas. The majority of those immigrants don't speak the language. You see all those factors build up to create a need for a new approach to public health. So urban health takes advantage of the modern way of living, different from the traditional old way of living where people lived in rural areas. People are living in much more close quarters. Disease spreads easily. To prevent disease, we need clean air, we need clean water. Those things become so important in urban settings. So to answer your question, Javier, the new environment, which has brought many people to live in close quarters, calls for us to look at public health in a new way that addresses the population density, that addresses the need for clean air, that addresses the need for clean water, as well as the climate as well. So public health, focusing on urban health, you can call it a new wine in an old bottle, but I see it as much more than just that.
Thank you, Phil. I think it was very enlightening for those who are following us. And before just giving the word to Malachias or to Luis, so in addition to what you mentioned, we should be aware of so many other factors in the definition of what is urban, or what is a city, or what is a mega city, and how things change so much between the developed and organized countries versus the less developed countries, where the concept of mega cities, very different to talk about New York City as a mega city, to talk about Mexico City as a mega city, or so many other huge cities that like where even the access to healthcare is very limited within the cities. And just before that, just to elaborate with another, to enrich the conversation, just in addition to, the aim of public health is to intervene, to modify the pattern of diseases. That's the purpose. And through that, we can do it, understand it, how it spreads, how the distribution of it, the epidemiology of it, of course. But the other part is the organized response, Phil, to these problems. So how we, as society, organize our policies and health services to face these challenges that we face in urban cities, so to speak. So from there, I guess it starts like spreading in a bigger area, just the basic concept of urban public health. Just to contribute with that. So which of you two you want to continue with this? You Luis, please.
Well, I just want to start by saying that I agree with Phil. This is more than new wine in old bottles. And the reason is that we have neglected in public health the incorporation and the discussion of different factors that are related to changing the composition of the countries. And now Mexico is more than 75% urban, and then our problems are urban problems, not rural problems. Although still we have what we call a polarized country, but the country is polarized in a different way because we have in rural areas other problems that have to be solved, but we have big neglected programs in the urban areas. And one of the main things I would like to say is the concept of community. When I started study community in Mexico, community means the decision-making at the community level. The life of people related closely in closely nets in the community level. And it doesn't happen anymore. There are no more communities like that in our cities, of course not. I live in a 7th floor building and I know nobody. So we have the only community ingredient is the policeman that let people get into the department. And therefore, this need to define what means really urban, and the field was doing a very good job saying, okay, what is urban is the fact that we have migration, we do, is the fact that we have people that come to the cities without speaking English, or in our case, Nahuatl and other local languages, and also that they are in conditions of living, living conditions are really poor, because they come to a city and they live in the fringes. And in those areas, they don't have enough resources to really have a good life. Therefore, I think one of the main things that we need to do is to discuss first, what is the concept of community in urban areas? And from there, to start to talk about, is this the basis for the public health, the community? Or do we need to come out with a new concept for urban health that incorporates participation in a different way?
Thank you, Luis. I think that you can introduce a very interesting subject, which is something that we have heard so much time, that how we always make planning for health has to start with the basis of the community level, from there up. How this is being forgotten in the mega cities, where many of the policies are forgetting about the idea that where's the community in the mega city? Is that still the cell of the community of the city or not? And how policies are introduced without taking this in consideration. Because regardless of whether it's urban or rural, the community is what is the basis of any beginning to understand what is going on in public health. So thank you. This was very, very interesting. Malachias, any words of thought?
It seems that I will have less noise in the environment now, but what I want to point out is that there seems to be something happening from time to time in the world, and we from the field of public health react to what happens outside and create different visions of public health. Yesterday, I was discussing with a friend from Johns Hopkins about the phenomenon of the non-pharmacological interventions that have been mentioned in regard to COVID-19. And there was a lot of mentioning in the recent conditions, expressions in the world, in academic papers or elsewhere, about the power of non-pharmacological interventions. And that is the power of public health. That is to speak about the possibility of trying to stop, in this case, an epidemic, a pandemic, by means of public health measures. These are the non-pharmacological interventions. So there seems to be a condition in which public health is not identified neither by professionals nor by the community as a way to enhance the possibility of responding to the problems, the health problems that are being experienced by the community. And in this case, we apparently have been surprised by the fact that the urban environment is not the same as before, or is different in this case from the rural environment. And we have known that for many years, but we have not experienced the sort of problems that we have now. With large and poor city in particular, we have favorable conditions for the spread of diseases such as COVID-19. We previously thought that the infectious diseases were harnessed and that we could not, we had all the means to avoid them or keep them under control. And we should worry about the development of chronic conditions. And these are more typical of development and more evident in urban settings. And we began to discuss about the new era of chronic diseases without too much regard from or for epidemic, I mean, infectious diseases. But right now, it sort of explodes in our face. And then we realize that we have a different, not previously known conditions in the world for which the spread of diseases have different settings and different possibilities. And we react in some sense saying this is a new predominant environment, the urban setting, and we have to focus on the peculiarities of the urban setting now in contrast to all the settings or the rural settings, and we have to be very careful. I guess that what is important in the bottom is that we have public health, and that public health is not medical care. We have two big chunks of possibilities to fight against disease. One is public health, the other is medical care. And sometimes, like in now was evident for COVID-19, medical care is powerless. Medical care cannot stop it and nor treat the people that are affected by this disease. And there was only the possibility of acting from the point of view of public health. So this is valid for urban settings, which are more important because they concentrate the biggest chunk of the population, but it was also important for rural settings. And we cannot rely on one single way to respond. This is particularly relevant in Mexico now because we have a crazy president who thinks that what we need in Mexico is specialists in medicine. And probably he thinks that we need hospitals and that this is the way of fighting disease. But the possibilities of not fighting disease, but promoting health escape from his view and the view of others who are working in the Secretary of Health in Mexico, and they are not really professionals of the study of health in populations. So we must stress the peculiarities of this approach, this new approach that is being promoted of urban health, because there are peculiarities to the cities today that were not present before. And we have to teach our students about, but without leaving our initial position of favoring something called public health. That is the important background of all the discussions, I guess. Thank you.
Thank you, Malachias. Before Phil takes the microphone, I just want to wrap up what we have heard so far. And basically, what I'm listening is the fact that the challenges in the urban settings called small cities or mega cities are evolving rapidly. This 21st century are constantly changing, facing different challenges in the policy level, but without forgetting the community level. That's very important. That's to be aware of it. And in addition to that, all the complications that we're facing as a society with these migrations from many countries. Mexico has all these people from Central America migrating to the United States, but they stay in Mexico. So they modify the demographics and the epidemiology of what we are observing. But when we have the pollution and the mental health issues. So I believe, just to wrap up this first cycle of arguments, is that more than ever we have public health to stop, to make it very clear that this has to be more than ever a multidisciplinary approach. We need every expert in every discipline to face the challenges, which are huge in terms of health and disease. Phil started saying, let's remember that the best public health is when we make sure that we have drinking and potable water to the people. If we cannot provide that, then we're talking about another kind of situations. What about the sewer system, all these things that come along? So you started with that, Phil. Of course, that goes into many other issues. But Malachias says, how much money is put into the medical approach of building hospital and keep developing specialists, when the challenges have nothing to do with that. But anyways, most of the money goes into that, and pharmacological research is huge monies that really don't make a difference in terms of community health. So having said the above, Phil, do you want to sort of like make some comments about what you've heard, just to enrich the conversation? And after Phil, I would like to, because time is running, to close this conversation and roundtable with something that has to do with both departments, which is the education and the teaching of the new generations of public health professionals. What we have to be aware of it, what is the main things that we have to make sure that our curricula includes and incorporates, whether here in UMass or UNAM in Mexico City, which is part for the public that is listening to us, to following this conversation. UMass and UNAM are working together to have a joint program in exchanging students in public health. So this has us very enthusiastic with this possibility, and everything started with this conversation today. So Phil, please feel free.
Sure. I wanted to agree quite a lot with what Malachias said, and also what Juan said. Malachias touched on the pharmacological aspect and how it should be different from public health. The pharmacological aspect, to me, represents the vaccines for COVID-19, the medicines, the fancy medicines for different diseases. Those things, the vaccines, the medicines, pharma, they represent healthcare. And healthcare and public health are not necessarily the same thing. Health and healthcare is when you go and visit a doctor, when you need the medicines, the vaccines, and so forth. Public health is when we're trying to avoid the need for the medicines, the need for the pharmacological interventions. So, as a field of public health, epidemiology offers the tools for organizing our thoughts around how to be effective public health practitioners. I am sure your curriculum, I know we're going to discuss curricula after this, your curricula has strong epidemiology components, the tools that we need to start looking at things at a population level before we even go healthcare. Our curriculum will also emphasize epidemiology, the tools that we need to protect health before healthcare is necessary. So I'm pointing out that I do agree with Malachias. I do agree with Juan when he mentioned the community. The community represents the places where we live, the places where we work, the places where we play. So that's where public health is implemented, not in the hospital, not through pharmacological or medicines. So my point here, my main point is I'm agreeing with the two previous speakers about the distinction that is necessary for us to do effective urban public health or any public health, to make sure we do separate it out from the clinical side of thinking, the medicine side, the pharmacological type of thinking, because that's the end of the road. We want to be at the beginning of the road, because before those things become necessary.
Thank you, Phil. Thank you very much. This is very, very important. And I stress the value for those who are following us, that do not confuse. One thing is medical care has nothing to do with public health. Just remember, that's two different concepts. They're correlated because at the end it has to do with human beings, but public health has to do with prevention and everything we do to make sure that we don't end up in the hospital. Good thing that there are hospitals, of course, but public health and hospitals are a different story. Thank you so much. I'm going to give the microphone to our Dr. Laura Hyman. She is part of of course, the College of Nursing and Health Sciences, and very involved in this program or urban public health. So, Dr. Hyman, thank you for joining us, and thank you for commenting on this so far.
Javier.
Okay.
Sorry, thank you, Javier. Can you hear me?
Perfectly.
Great. I can't turn on my screen because I'll lose resources, but so much of what has been said just resonates with me. Right. I am a professor of nursing. I do have a strong public health background in terms of having worked as a nurse in clinical as well as clinical settings and community-based settings, including schools in the urban area. And a big part of what I do is prevention and health promotion, chronic disease prevention, which is inextricably linked with public health. Totally agree that the medical model does not apply. I'm reminded I teach social determinants of health. That's a big part of my research and scholarship as well. And Virchow, I'm reminded of Virchow and Geoffrey Rose, who so eloquently stated what we need to do and with a public health perspective. And I think all of you have spoken to this, including Phil Gona, that, and particularly in developed countries, let me back up and say there are differences in what's needed in urban public health in low middle income countries and developed countries, however we want to label them. But definitely a multidisciplinary, transdisciplinary approach, is critically important. And to that end, we need to prepare our next generation of public health practitioners accordingly. And there's so much more to say, but you all have been so involved in this, and I'm just joining the panel a little bit late, but I will say that it has been so informative and insightful. And having been to Mexico City with the World Congress of Cardiology, I know some of the challenges and opportunities there as well as all urban areas have, both challenges and opportunities. And so we have to turn those challenges into opportunities to promote public health, which is really promoting health equity for all. Thank you.
Javier, we cannot hear you.
You're muted.
Thank you for telling me. I cannot believe that it's been 2 years that we've been doing Zoom and we keep forgetting to turn on the microphone. We don't learn, something's wrong with me, with everyone. It happens all the time. Anyways, Dr. Hyman, thank you so much for your contribution. We value very much your comments. And you just started with the next topic that will be our final round, since the time is just approaching to the end, to talk about what is common between UMass and UNAM, which is basically education. That's our purpose, to educate. The universities, that's our main goal. Research is a tool to do a better education. But having said the above, I just would like to hear you. What do you see, what you envision in the future of public health professionals that we have to start doing now in the curricula and the syllabus, and the kind of approach that we have to put in our future professionals in public health now to face something that is rapidly changing, and 10 years probably will be different from when they are learning right now. So what kind of basis, what is the 101 courses on public health that we have to start thinking right now for the future, and how we can make sure that this multidisciplinary approach is guaranteed? And whoever has an MPH to start with, of course, the PhD will focus on whatever interest they might have, but a basic MPH, just think of that, which is the main structure for those who are willing to go into the field. What do we have to worry about it? UMass is starting to do a new program, which next year will receive students in the urban public health. Mexico City in the Department of Public Health, we're going to be working with you very closely to the UMass to see how we can benefit from this new curricula and modify the one in Mexico City. But I don't want to take more time. I want to hear you. Please go ahead, Luis.
Well, one of the things I was thinking when you invited us for this conversation was precisely the context of Mexico and the situation that we have at the Department of Public Health. I was the head of the department in 2015, 7 years ago. And at that time, it was clear that we were reaching the limit of the programs that we have already into place. I guess the time limit. They needed to be redesigned. They needed to incorporate new issues. And now we are worse. I mean, 7 years after, the program, to give you an example, the program of the whole medical career was settled in 2010. So it has 12 years. It is an urgent need to revise it and to incorporate things that can be making a stronger participation of public health in the undergraduate students. Plus, we need to do the same at the graduate level. We have more than 15 years since the programs that we already have in place were designed. And I think we need to do it in a very urgent way. One of the good things about this is that we can do it together with UMass and with other guys, with other friends, because I guess this is the moment of change. I mean, we need to incorporate these ideas into the curriculum so that we can have a modern view, an updated view of what public health can be done for the society. And I guess that for me is a way to say, let's collaborate, let's work together, let's share our ideas and try to fix the problems that we have accumulated during the last 15 years in Mexico, at least. Thank you.
Talking from the UMass side, I'm sure Javier, you know the way we came to become who we are. We started off developing an MPH degree program, and the university changed course and said, before you go MPH, why don't you start by developing the undergraduate programs in public health? We were a little disappointed by that change of gears, but now when I think about it, that was a good idea, in the sense that by first developing the undergraduate program, we're really going to the bottom of the problem, you know, nurturing a young cadre of students who are going to be future public health professionals, rather than starting from middle of the road, the MPH and maybe the PhD. So our BA and BS programs, they're slightly different. The BA is focused on the social determinants of health component of public health, whereas the BS, the Bachelor of Science, is focused more on the quantitative side of public health. So these two combinations is going to create two career paths. The BA is going to go into the behavioral, you know, social, whereas the BS is going to go into the more quantitative scientific research, the epidemiology that we talked about earlier on. And then with the lessons that we learn from the undergraduate program, we will build our graduate program on that platform, which I think is a good way to get started rather than start in the middle. So from UMass Boston perspective, we would like to learn from you how you implement your public health program. I understand you guys are with the medical school and your students are medical students who are not necessarily going to focus on becoming public health professionals. Our students are focused on becoming public health professionals. Your students are taking public health because it's a necessity for them to graduate. So we have things to learn from each other here. We are creating a terminal degree in public health. You are emphasizing on adding public health to your curriculum to students who do not necessarily want to become public health professionals. Our program, because we're creating a terminal degree in public health, our students have to complete a practicum. You know, the last semester of their program, they have to be out there in a community working for an organization that's doing hands-on public health. I would like to know what kind of experience your students do have to have real experience in public health, considering that their terminal degree is not public health, their terminal degree is in medicine. So we would like to collaborate here. Where I'm going with this is we want to see how we can improve our community engaged practicum in the community. From you, you also live in a big city like us in Boston, but your students and our students seem to have a different trajectory.
Well, Phil, I think that you just put the finger on the line that we need to talk about. Last session that we had, Malachias actually mentioned how important will be for you to learn of those programs that we have succeed teaching public health to med students. The challenge is huge. Of course, you're right. Those guys are there to become surgeons or cardiologists or neurologists. In the best cases, they would like to be family physicians, which is amazingly much better. But anyways, these are med students and they have to take public health. Believing strongly in the importance that any clinician understand that this patient comes from a family and the family comes from a community, and what he's doing is just a little bit part, he misses the horizon, is an incomplete physician. So that's part of the theory behind it. Before giving the microphone to Malachias, and with him we'll wrap this up, I just want to know this process to create this curricula, this new program in UMass in urban public health. Probably you went around and see what else someone else is doing in public health in the country. You probably went some needs assessment, all kind of analysis, assessments here, and copying the good experiences of other universities. So pretty much this program should represent the state of the art in teaching urban public health, because you are just beginning with it. Can you just elaborate very briefly in the process to come to this is the right design, at least for the New England region of the United States?
To answer that question, we were guided by the accreditation body. There is Council for Education in Public Health. They provide you a roadmap for what a degree program in public health should look like. So what we did is we took the basic components, the core components, epidemiology, biostatistics, and some communication courses. Those core courses everybody will take. But for the Bachelors of Arts, they have a certain pathway that they follow that's different from the Bachelor of Science pathway. But the curriculum is given to us by the accreditation body. They don't tell you what to teach, but they tell you what competencies the students should have. So in that respect, we looked at universities in the neighborhood, in the Boston area. We have Harvard School of Public Health, we have Northeastern School of Public Health, we have another program within the UMass system, but that has a different emphasis. And we say to ourselves, what is going to be our niche? What is it that's going to be different about our program that others don't have? We looked at our student body. Our student body at UMass Boston are non-traditional students. What we mean by that is we have students who have families, we have students who have children, we have students who have a job or two jobs, or students who live with their parents at home. So those students would not be seeking admission at Harvard School of Public Health. They wouldn't be looking for a full-time educational experience. Those are the students that we have in general at UMass Boston. So we created a program that's suited for our market being our students. And of course, we did some market research, looking at the job prospects within the Boston area or nationally, that our students are going to be useful in healthcare agencies, some non-governmental organizations, or some clinical settings where they will be spearheading research. So to answer your question, Javier, we did a market research, number one, on the kind of students who are going to come to our school. Number two, the kind of jobs that will be suitable for those students. And then, of course, we separated the BA from the BS for obvious reasons.
Excellent. Already we have a lot of things to share.
I have a question. I understand that there is at least one other school in Boston that offers a BA in public health. I guess it is Tufts. I don't know whether you have connections or have analyzed their experience in that point, in that regard.
So that's an interesting question, because as part of our approval process, we're supposed to get feedback from local colleges that offer degrees in public health. But there's a catch. These colleges, these universities that offer programs in public health, as much as they are in the same field as we are, but they are also competition. So for them, us entering into the public health arena was like, we're going to be competing for students with them. So in the initial rounds, when we were talking about the MPH program, the kind of feedback we received from the competing institutions was like, you don't want to do this, as if they were being protective of their turf, as if they're being protective of the students that they are going to be competing against. That's why when we chose the niche for urban public health, we stuck out against everybody else as a way of getting around the competition in an innovative way.
So
Interesting.
Can we now, Malachias, continue with the microphone just to wrap up, going back to your perspective on envision the education of public health professionals in Mexico for the future now?
Thank you, Javier. Well, the point I can try to discuss is how to educate a physician in public health. This is our problem here. We do not have the possibility at UNAM or at the School of Medicine yet to offer a degree, a terminal degree in public health. There are two schools in Mexico that are doing that. Our setting is different from that you mentioned, from what you mentioned in Boston, because here in Mexico, we have a system of public universities funded by public funds in general. So having a degree in Aguascalientes and another one in Michoacán is like an experimental camp for all public universities in the country, and to decide in the future whether or not to follow that path. But in the meantime, what we have been struggling with for a long time is how to give some orientation to physicians who are going to work as physicians, either in community settings like being family physicians, or in general practice settings, or in specialist fields, and induce them to at least take into account the possibilities of public health, and realize that not only medical care can be provided to the community, or that sometimes providing medical care to one person has a very little impact in the health of the family or in the health of the public. I mean, positive impact, but it has lots of negative impacts, in particular economic impacts. So what we have done is to try to induce the medical students to have early contact with the community settings. We try to send them to health centers to get in touch with whatever is happening in the community, and the way that people are being provided medical care in the not as hospitalized, but
ambulatory care.
Ambulatory care, and then throughout the career, offer the students a few tools, like, for example, review the tools of clinical epidemiology that are much more applied to medical care, and to understand that the development of knowledge about the disease and ways to change the future are derived scientifically from the application of epidemiologic tools that were not previously developed by the practitioners of medicine by themselves. And then at the end, our students have to spend 1 year in a community setting. We call that the social service. So you cannot get out of the medical school in general in Mexico, not only at the UNAM, without spending 1 year that we call the social service, that is mostly working in community settings, sometimes in small towns, in the rural settings, but many times in urban positions in different types of medical care services. But going back or trying to wrap up, what we have experienced so far is how to teach some public health to future physicians. But we have not developed too much experience, and we are not working with the process of forming public health professionals. So this is going to be a very interesting experience for us, I guess. I don't know what Luis may comment on that, but from the point of view of the importance of public health in the health of communities, I guess that the future calls for the processes of forming public health graduates. Thank you.
Thank you, Malachias. 1 minute, Luis, please.
Just very briefly, I want to use the minute. Malachias and Phil have said many times the word community. In two senses, the community as a place where we intervene and a place of action. But the problem is that what is the community? If we want to intervene in public health, we need to develop a new concept of community that enables us to work on it. What is a community intervention in an urban setting when the people are not really working and living in communities? So the challenge is to change the frame of mind that we have in teaching too, because we in medicine send the people to rural areas for the social service, not to communities. In the rural areas they work in an ambulatory setting, receiving people. They don't do community interventions. Therefore, we need to talk about that deeply.
Thank you, Luis. I think that's a very important concept. And this is just the first roundtable that we have. For all you guys who are listening to us, we're going to come with more meetings like this. We'll let you know with time. But Phil, I think that is something very important for the experience already about to approach the concept of community. What are we talking about when we say community?
Right.
And if we make sure that your students are approached and exposed to the community, so let's define what do we mean by community. So we just have some 30 seconds left. Phil, go ahead, please.
Right. I'll quickly say something. I was hoping my colleague, Dr. Hyman, would say something about the community as well. But I will tell you our experience at UMass Boston. Our program is not opened yet, but we have a plan for defining community as one is just asked. So the way we're going to do things is in the year before the program opens up, we are going to set up some community advisory board, which means to say we get in touch with community leaders, churches, health centers, and invite them to become part of our think tank, people who tell us what's going on in the community, the needs for the community, and how our program can be used as a vehicle to enter those communities. So we just don't go into a community and do things without consulting with the Community Advisory Board. The Community Advisory Board will be our eyes and ears on the ground in the community. That's how we define community one. The links through the Community Advisory Board is our link to the community. If we just went into the community without consulting the advisory board, our efforts may not come to anything. But if we're guided by the advisory board and they actually lead us to places where we need to be, that to me is getting into the community and possibly engaging community leaders in some of our activities so that they become our advocates even when we are not there. And when we have to work with students or recruit students, we're recruiting the students from the same community. So our definition of community is more expansive than that, than just the individuals we're talking about. So I hope that addresses your comment, one, about what we mean by community.
Definitely,
I'll
Phil.
add to that since Dr. Gona, thank you so much.
Yes.
Thank you for sharing that. The community advisory boards are critically important to any community-based initiative. And as Dr. Gona mentioned, we plan that. That's part of what we're doing going forward. I'm also a member of the Community Engagement and Advisory Corps for our Cross UMass Clinical Translational Science Center, which with a major goal of community engagement. And reaching out to communities with the science that's generated from basic to clinical to population science. And recently I had the opportunity to participate in a 2-day invitational at University of Michigan with public health expert, behavioral folks. And the theme was how to optimize synergies among communities, families, and peers, as well as community health workers. And this topic, what is community, was widely discussed, and community can be operationally defined in a variety of ways, as we know, geographically, as well as by attributes and characteristics shared by individuals. Is that clear?
Thank you very much, Dr. Hyman.
It's a working definition.
I believe that this will be a topic for a next roundtable because the theme is so broad that will give us many more times to share. And well, we're at the end of this. I have to say, as the topic of this conversation, one of the risk factors for organizing a roundtable like this is time. So time might be a risk factor because it limits our presence and stresses the coordinator to finish on time. So it's a risk factor to my health too. So given saying that, I think that we're at the end of this. I just want to thank, of course, our good friend Phil and Phil Gona, Luis Durant from Mexico City, Malaquias Lopez Cervantes, again from the University of Mexico, School of Medicine in Mexico City. Dr. Hyman, thank you very much for your company, for your presence and your comments. And I just want to thank you, all of you that have followed us on this roundtable today. I appreciate your generosity with your time, and we invite you to follow us in the next roundtable organized by UNAM Boston. Thank you very much, and have a very good day. Thank you.
Thank you. Gracias.
Thank you all. Nice to see you.
Salud.
Bye.
Take care.
Nice to see you. Bye-bye.
Nice to see you.
Bye-bye.